Good morning, everybody, or wherever you are. Welcome, and thank you for joining us. My name is Dr. Angela Anderson, and I am the program coordinator for the Epidemic Urbanism Initiative. Today, our panel is titled Health Equity in Architecture at the Intersection of Teaching, Archive, and Curating. This panel is part of the Epidemic Urbanism Initiative's online series of webinars, panels, and interviews. Co-founded in 2020 by Dr. Mohammed Garipur and Dr. Caitlin de Klerk. At the start of the COVID-19 pandemic, the EUI works with a global community of scholars, designers, and practitioners to create dialogue around issues related to architecture, space, and their relationship to epidemic diseases. We also work with health equity. The pandemic drew attention to the inequality of healthcare around the world, and the EUI has continued to coordinate panel discussions, publish an edited volume, archive our collection of open source teaching videos, interviews, and other resources that can be used to learn and teach about health and the built environment. The EUI is now a didactic hub, developing and presenting learning materials that focus on the implications of the relationship between various aspects of health, from historical quarantines to healthy cities, and to teaching design and architecture. We have two webinars featuring the 2023 EUI International Design Competition finalists and juries with a focus on adaptive reuse and health equity in localized contexts. We ran the competition in two categories: Community Health Center and Emergency Treatment Center. I would like to draw your attention to these resources on the EUI's website and our YouTube channel, as well as other modules that can be used in the classroom. You can please visit our site or email us at epidemicurbanism@gmail.com. The EUI is fortunate to have a community that includes a board of experts, almost 3,000 learners, practitioners in architecture and healthcare, scholars and professionals, and a team of regional liaisons from 5 continents. In all, our global approach is based on the contributions of talented people from more than 90 countries. I would like to express our appreciation today as well to the expert panelists joining us, who you will meet in just a moment, and to the chair and moderator, Dr. Meral Kinjiolu, part of the Society of Architectural Historians Historic Interiors affiliate group and an accomplished scholar whose analytical work on architectural archives has shed light on the institutional exclusion of women, racialized groups, and other minorities from these documentation systems. I look forward to the discussions today. Thank you all for joining us.
Hello, everyone, and welcome to our online panel, Health Equity in Architecture at the Intersections of Teaching, Archive, and Creating. And as a panel chair, I am Meral Ikincioğlu. And why health equity in architecture and why at the intersections of teaching, archive, and creating, if you ask? As our global COVID-19 pandemic experience, climate emergency, and other urgent challenges have clearly shown us that if underrepresented minority and disadvantaged communities and individuals are not taken into consideration, it is not enough to provide health opportunities for only some people. In architecture today, we need to re-examine our design understanding and cultures to provide fair health opportunities for everyone within the built environment. And for this, we need to reconnect fragmented domains of architecture. In this respect, the current role of architectural teaching is vital for a positive transformation and for the internalizations of health equity by young students with a holistic perspective. To support this, it is also vital to construct and develop our collective memory on health equity in architecture, because some answers to our problems and potential resolutions are hidden in these realms. In other words, in our architectural archives and collections. With this perspective, our panel today aims to establish and develop productive dialogues among teaching, archival, and curatorial communities. And since health equity in architecture is a broad topic, our panelists are from diverse architectural cultures to offer a rich perspective on this subject. Now, please welcome our esteemed panelists. Dr. Elke Miedema is a researcher and teacher at Inholland University of Applied Sciences in Netherlands and co-founder of Healthscapes. With an academic foundation, she excels as a researcher and educator, focusing on the evaluation of healthcare systems and their impacts on health facility design. Dr. Aaron Davis is a lecturer in architecture at University of South Australia with extensive experience in design and facilitations of complex co-design and co-creation processes. He has strong experience in industry-linked teaching with an emphasis on design for health in architecture. And Dr. Nilay Evcil is a full professor in architecture at Beykent University in Türkiye. With her 25 years of experience in research and teaching, her major focal points are inclusive design, accessibility, urban design, quality of life in cities and public spaces. She is a leading professor studying and offering her courses on architectural design for all in Turkish architecture and has several published books and essays on her expertise fields. Dr. Julie Collins is a research fellow and curator at the Architecture Museum, University of South Australia. Her interests range from architectural history of therapeutic places to study of architectural drawings, collections, and heritage. And her recent books is Architecture and Landscape of Health, a historical perspective on therapeutic places between 1790 and 1940. And Kadir Uyanik is a co-founder of Docs Architecture, an accomplished architectural design office in Türkiye, worked as an instructor for interior design studio at Kültür University in Turkey, in Istanbul, won several national and international architectural competitions. As Docs Architecture, Surgical Instruments and Health Museum in Samsun, Türkiye is among their significant projects with their experience in documenting an exhibition on the development of surgical instruments and knowledge of medicine. And after our panelist presentation, we have question and answer sessions and would be happy to know questions by our audiences. And if you would like an answer from a specific panelist, please first write your questions and then mention the panelist name during our question and answer session in our chat box. And now I would like to ask our panelists to learn their inspiring experience, challenges, and suggestions on our panel subject. According to your experience in the field of teaching or historical documentation and curatorial practice, what would you like to say about substantial gaps in health equity in architecture and what can be done to fill these gaps? And what can be done to develop productive collaborations among teaching, archival, and curatorial communities in architecture to support teaching health equity in architecture? I would like to begin with Elke. Yes, Elke, the floor is yours.
Yes. Thank you, Miral, for having us. My name is Elke Miedema. You already introduced me, so I can skip to the next slide, I think. Here. Yeah, so since 2006, I've been interested in the role of architecture for human health, and I build upon many others who have already showed that the built environment can influence health, what also was already mentioned, but also that the built environment can influence health inequalities, and therefore it becomes of paramount importance that designers and therefore the education pays attention to how the design of spaces of health, care, and cure fit for all, regardless of people's abilities, backgrounds, and values. Within the larger domain of research on architecture for healthcare and cure, I focused in building design for the transformation of health promotive healthcare. I refer to the processes of designing buildings that enable vulnerable individuals and communities to take control over factors that positively influence their health and quality of life. This thus means a very holistic, human-centered approach to design. It pays attention to health rather than just illness. And it has a very strong social justice and equity component. So this also, it's because it comes, health promotion as a concept comes from public health and a health equity focus. And yeah, I just want to talk to you about a couple of examples of how I'm trying to overcome these gaps between the knowledge of like general architectural education and the directions that we want to go to as part of architectural profession to take up health equity. And that, of course, includes processes of empowerment and participation, but I think Alan will also talk more about a multidisciplinary collaboration. So just a bit background, I've been teaching since 2010 in architecture and building engineering, and I worked in the Netherlands, Belgium, Sweden, in different knowledge institutes, but also in practice in architectural firms on bachelor, master, PhD level, in courses that involve design for healthcare and cure. And I've learned from many before me, of course. So I want to acknowledge their share. And what we, so whatever time I have, I always start with whoever is in my educational group, like with the vocabulary surrounding design for health equity. So what do we actually mean with universal design, inclusive design, age-friendly, social design? And then I also take them into the discussions that these words actually vary very much depending on the regions as well and how this is interpreted. And I give them this vocabulary if we only see them shortly, so they can leave after a lecture or a seminar and search more information themselves, of course, but also to really get to know and understand the different interpretations of this and what that actually means for design. When we have a bit more time, I will also discuss the larger vocabulary surrounding designing for specific target groups. So for instance, do you say, I design for disabled people, I design with people who are disabled, or people that have disabilities, or people that, so there's, and I still struggle with these words because English is also not my native language. And of course, the preferences of how you talk about this change depending on the individuals as well. But we have this discussion in the class to be able to learn how to reflect upon the words that are being used. What I see as one of the struggles is that there's a whole domain about design for health equity. And I really always try to focus on how do you combine different health-focused design aspects. So health equity and health behavior and design for planetary health. And within the education, we also discuss like, okay, what are the different ambitions for each and the strategies, and where do they overlap or contradict? This is a bit of a strange example, of course, the inclusive design, the elevator for people who cannot use the stairs, but you need to take the stairs. And this seems to be a joke, but this is very often happening. And with the students within the education, we try to show that by knowing the multiple perspectives, you can actually find symbiosis and create spaces that promote physical activity, but not just for people who are having a fully functioning mobility, but also for people who have other forms of mobilities. A large role of that is, of course, participation, not only to understand the needs of the diverse populations that you're interested in, but also to empower them, to take them as part of, be a spokesperson, and take them into the processes. And in the education, I often share one of the studies that I did about this hospital in Sweden, where as part of the urban development, where there was a lot of issues with health inequity, they use the process of designing a new hospital in the neighborhood as a planning process to involve the people that lived around there and that were often excluded from conversations in general. And for instance, they asked the local population to participate in the development of the whole branding, the identity of the new hospital. And in the jury, there were also spokespeople from the communities. And yeah, so the pattern that you see here on the balcony glass that repeats everywhere in flyers, but also in facades, and that's a result of the design competition. It's of course difficult to incorporate such participatory methods in design education. So what we often have done is that the students first immerse themselves with literature to be able to filter out all of the questions that they can already gain from there. Then they can use social media, but they've also used interviews and site visits as part to really get to know who they are designing for and understanding their specific needs, wishes, and values. And what I'm really proud of is the work that I've done with Birgit Jurgenhake in TU Delft, is where the students could actually live sometimes in healthcare facilities and really get to know the people that they were designing for through their field work, space, and user observations. Then based upon that work, we help them to develop user personas and user journeys. And then this is also something that is very tricky, because what often happens if you don't have that data beforehand, then this can become like almost a caricature of a population and a simplification. And throughout a day, a seminar, we discuss with the students their personas and the journey and what kind of information they still need to be able to do that in a respectful way. And I think this is also a difficult thing relating to archiving, but also general access to data and health equity ethics. Like, how do we handle access to data? Can we use the current data? Because it often says like the elderly, where there's no attention to differences between these populations. So the existing research is often doesn't provide a complete image of the population that has been involved. It's also difficult to collect your own data with the ethics that you're putting upon a department that needs to put in time. But also the pressure on the healthcare system that we actually do need this. So we need new ways of archiving this to create more open access data collection and respecting individual time. I just want to show this, that I also collaborated with the Dutch Institute of the Archive of the Dutch Creative Industry. And we also worked a bit with using more what was archived to show also in the current perspective how the transition from history to the futures were. But I'm not so familiar with the archiving. I want to finalize. Thank you very much. I would love to talk more, but I'm interested in the other panelists today and having the discussion. Thank you.
Thank you, Elke. And yes, Aaron, the floor is yours. What would you like to say about our panel question?
And the panel question about the difference of the most important difficulties. And I think that's kind of what I summarized in the presentation. So the difficulty of like, how do we talk about this? How do we discuss these topics with architects? Like, do we have the vocabulary? But also, how do we, you want to involve people, you want to really understand people that you are designing for, but how can you do that in a way without constantly asking much of them, even though they're already, it's more difficult to share their perspectives, etc. So they don't get tired. Yeah.
Thank you.
That's such a fantastic segue into what I'm hoping to share. So thank you very much for the invitation, Maral, and for everybody for your attention. Before I begin, I do want to acknowledge that I am coming to you from Ghana country in Australia and acknowledge the elders past, present and emerging of the country in which I am from. In my 8 minutes that I did promise, I may go slightly over 8 minutes, but I'd like to share 3 ingredients that I am trying to bring into all of my teaching in this space around health equity, before then providing an example of a model I've developed through an international research project that sets up a framework that I think is really useful for trying to educate the next generation of architects as we move forward with a health equity agenda. And then finally, having a few conclusions about what this might all mean for architectural education and for collaborations, particularly with the archival sector. So the first ingredient is something that I've noticed quite often in the politics of healthcare facilities is that healthcare facilities are quite expensive. And this slide provides an interesting provocation, I think, that the Palazzo in Las Vegas and the Shard in London have a few things in common, but one of them is that each cost $1.9 billion. And interestingly, a hospital in the city I'm from, in Adelaide, South Australia, costs $2.1 billion. So our healthcare facilities are incredibly, incredibly expensive. And what this is leading to, certainly in an Australian context, is a focus on finding efficiencies and trying to reduce the costs of these buildings. But my argument is often that these efficiencies are an artificial efficiency, and our buildings are becoming artificially cheap because we are doing things like I've highlighted down the bottom there of excluding marginalised communities from their design. And that's a cost that we pay as a non-financial cost in exchange for arriving at a lower financial cost. So calling that out is something I'm very keen to do with my students, as well as to advocate for politically that it's not okay to exclude our marginalised communities from our health facilities. One of the ways this is enacted in healthcare design is through the use of very strict, stringent design guidelines. So in Australia, we use the Australasian Health Facility Design Guidelines, and there are many equivalents around the world. And these design guidelines set a baseline, an absolute minimum standard, but we often defer to that in the name of this artificial efficiency. What's interesting about design guidelines is that they are formed in a very different way from clinical guidelines, which are based on huge amounts of data and evidence, while design guidelines are typically based on what did we do last time and was that all right, with very, very little evidence to back that up. Second ingredient is about how we engage with our communities when we are engaging them. And one of the challenges that I often see, particularly around architectural projects engaging with marginalised communities, is a resistance to the idea of giving over decision-making power to a minority group or to a smaller group. And I always counter that with this idea that there are different types of engagement that we do. And this is an example I use with health practitioners, that you're not going to engage somebody in a decision about what scalpel a surgeon should use or where they should start and end an incision to do a surgery, but you are wanting to engage them in whether surgery is the right option. So some work I commenced in my PhD studies and have continued is around this idea that we can engage with people in a dialectic manner, which is very focused on outcomes. This is stems out of Hegel's work and philosophy. Or we can engage in a dialogic collaboration, which is focused on high quality processes and finding insights all along the way, rather than being obsessed with decision-making or outcomes. A couple of years ago, we published an initial framework that was setting out to test when is it okay to give less control over outcomes, but to engage in deeper processes, and when is it required that people do have control over the outcomes when you are engaging in these processes. As a reference to the paper, but essentially this area highlighted in pink, we argue should not be done. But everything above that line, there are instances that we've explored where it might be okay to do those sorts of approaches. Third ingredient is about changing our perspective on how we engage. And this is something that is challenging to bring into the classroom. But through research work, we're looking very much at how do we start from our participant group rather than our own convenience. So working through a spatiotemporal framework in this instance to define what might work for our participants. This has been really interesting through the pandemic because, as this quote illustrates, this was Dion Detterer, who lives with muscular dystrophy. And his quote here that it's the first time he's felt like an equal participant was from a fully online engagement. And this really challenged us to think that perhaps our same time, same space or our face-to-face co-design workshop wasn't actually working for everybody. It's working for generally white, middle-class, wealthy people who can spare a couple of hours during the day, but may not be working for some of our more marginalized communities. So we really try to explore different options for how we might engage people in the evenings, on weekends, in their place of residence, and at through different modalities as well. So to illustrate a bit more about these ingredients, I thought I'd just share a project that I've been working on for about the last 4 years or so, which is the Neuroscience Optimized Virtual Environments Living Lab. It's an example of how healthcare architecture might be done in a different way. I have a number of project partners and collaborators there. I do want to acknowledge this is the lead research team. It's quite a large team, and there are many more other people. We have 104 co-researchers involved in this project. We also have a fantastic steering committee with some names those familiar with healthcare architecture may remember around the world. But in this project, we ran a series of online workshops because of the pandemic, but this opened up a huge number of new participants to us that wouldn't otherwise have had the opportunity to participate, particularly a lot of our stroke survivor community, because this project is focused on the design of subacute rehabilitation post-stroke. We discovered that these online workshops we were creating back in 2020 could also be used asynchronously. So we could provide people with more time and the opportunity for people living with aphasia, as an example, to spend time with a communication partner working through this at a pace that worked for themselves, something we've never been able to do with our typical mode of running a workshop. We ran both virtual and physical drop-in spaces to allow people to come past and have a discussion about the project, make their contributions again at times that suited them, and through the virtual hub at a location that suits them by opening up participation to people, particularly in regional and remote Australia. Of course, there were the obligatory face-to-face workshops, which we all love, and the opportunity to come together is still a really valued part of projects like this one. But we also found some value coming out of hybrid workshops and the ability for people to have some asynchronous follow-up after the event. And particularly it was those who come from our stroke survivor community or those who are typically more marginalized in the processes that were engaging more through those hybrid and asynchronous modalities. So the outcomes from this project are a whole series of designs in a gaming engine, new ideas for services, and ideas for how we integrate these together. But what's really critical and something we're keen to educate our students on is going beyond a binary notion of which is better. So we've look at these two examples and we all kind of gravitate toward the Netherlands example here. But how to actually generate some evidence on this is a question we've been grappling with. So treating them as a soup problem or as bowls of soup and not trying to actually identify individual ingredients, but to look at them as a whole and to be able to compare things as a whole enables us to do a much more holistic and a much better evaluation. So we used value-focused thinking to determine what it is we should be evaluating these facilities based on and what the objectives might be when we design spaces. And all of this is available as some really great inputs for design studios as some really nice challenges to set students. Things like how can you maximize access to a positive and stimulating environment or maximize outdoor and green spaces, maximize versatility, those types of things. So in summary, I think we need to teach our architecture students what healthcare design guidelines are and are not, and particularly to call out where they are just seeking economic efficiency. teach students how to ask appropriate questions and how to value long-term engagement that's not focused on decisions, how to construct and deliver value to marginalized communities by taking a participant-centric engagement practice. And then when we reach out to our archival and curatorial communities, I think we could really contextualize a lot of what we're doing and understand where these standards have come from, because a lot of them just appear to have come from thin air, but there is a long history that has led to them being the way they are. I think we can enrich our dialogues and bring examples from beyond current experience into our engagement with communities, and hopefully over time demonstrate how our social, political and cultural contexts are manifest through our healthcare facilities and services. So apologies for the very whirlwind, but hopefully that gives you a snapshot into the kind of work that I'm interested in and what we try to bring into our studios down in Australia.
Thanks, Aaron, for these very informative presentations on our panel questions. And now, Nilay, the floor is yours.
Thank you, Meral, and thank you for this organization. My name is Ayşe Nilay from Istanbul Beykent University, Türkiye. I teach universal design courses in my department to architecture students and interior architecture students as well. I begin to my lectures with Brian Lee Jr.'s words. He says that for nearly every injustice in this world, there is an architecture, a plan, a design that has been built to sustain it. Then I asked to my students, then can you describe me who is a disabled person? They try to describe or give the answer as describing a people who is using a wheelchair or who is using a crutch or a white can. But after this answer, I explained that actually there is no disabled people, but there is people who are architectural disabled. I mean, disability can be removed by improving the interaction of people with the built environment. And then I introduce them with the concept of inclusive design. By the way, the previous speakers, Elke and Aaron, explained the concept, but I sometimes use the same word as inclusive design or design for all or universal design as the same meaning. So in a very short explanation, I can say that the concept, inclusive design concept, is the design of products and environment to be usable by all people to the greatest extent possible without the need for adaptation or specialized design. So as we designer or as we architect, we can and we should make our world as accessible and as usable as possible for diverse users. In my lessons, I try to give my student a wider view to gain a deeper understanding of the user's context, pain, needs, wants, and the concept about what is normal. The reply is lying on the universal concept, I believe. Therefore, I told them universal design is the liberation for everyone. If I come close to health equity, which is today's topics, I may also say that health equity is a broad and complex topic as well, like universal design. But I can define simply as having a fair opportunity to be as healthy as possible. As you consider, health is also affected by environmental factors such as physical and information access. These factors can be either facilitate or can be either create a barrier. From my point of view, inclusive design in architecture contribute to our health and well-being through accessible buildings, spaces, and transportation vehicle is widely acknowledged. In other words, inclusive design can be the catalyst for equity in our building spaces and communities of tomorrow. And there are several shared goals and design strategies among health and inclusive design initiatives. If I can give some details, some example, I can tell improvements upon ergonomics. Physical and mental health and safety not only serve to create healthier environments, but I can also say that they can contribute to better spaces for everyone. Another example can be taken from design strategies such as exterior pedestrian amenities, interior circulation paths, adjustable seat and stand workstation, and spaces for physical fitness that include options for people of all abilities, which greatly enhance the opportunity to improve physical health. In my lessons, I try to create empathy. So what is empathy? Empathy is the ability to put yourself in another person's shoes. I believe that architects need to build empathy for their users in order to increase their quality of life. It is important to understand how the user feels when interacting with a certain built environment. As you know, also architects spend time getting to know the user and understand their needs, wants, objectives. This means observing and engaging with people in order to understand them on a psychological and emotional level. In other words, I may say that to promote and to ensure health equity, we need an inclusively designed cities. I have a lot of things to share with you because this thought and this strategies has a lot of is a very big strategies and thinking, but I should respect to my time and want to finish my words with another researchers, Davids and Lifshitz statement. They said that access for disabled people should not be viewed by architects as constraint on architectural design, but should be conceived of as a major perceptual orientation to humanity. I believe that universal design is for healing the world. This architecture thinking is like my North Star. I believe that the inclusive design principles will continue to support and inspire architecture world for designing more livable and more healthy environment in the near future too. Thank you for listening and inviting me.
And thank you, Nilay, for your presentation. And now I would like to ask our questions to Julie.
Hello, thank you very much, Meryl. I'm really, really pleased to be here with everybody today. And I will just share my screen with you all. So I too would like to acknowledge the Kaurna people on whose land I am presenting from here in South Australia, and respectively acknowledge them as the traditional owners of the lands. One of the gaps in architectural history, understanding, and archives is that too often architect-designed buildings have been assessed from an aesthetic or stylistic perspective without a full understanding of other rationales behind their designs. However, it can be seen in the buildings designed for health that the foundations of their planning, aesthetics, services, and materials were generally related to understandings of medical theories and treatments common at the time of conception. By using architectural collections, including plans, photographs, and publications, one can discover much about the ways people and their illnesses were perceived and treated, and how buildings were intended to work to improve the health of the users or inhabitants. By better understanding buildings, we may be able to better reuse them or adapt them to our current purposes. And importantly, by exploring the inequities of the past through buildings, we can aim, hopefully, not to repeat them. Since the late 20th century, historians have been exploring different histories of places designed for health, debating whether they improved the lives of the inhabitants or oppressed them. In particular, asylums, sanatoria, quarantines, and leprosaria have been singled out for censure. However, critiquing architecture through judgment of what occurred within the walls can also be problematic. Therapeutic buildings and their grounds use various mechanisms to enable health and treatments. Among these were isolation, social segregation, access to clean water and fresh air, and recreation, occupation, and exercise. All these produced and reproduced the contexts, and thus the health inequities of the societies in which they were applied. Today, I'm going to focus on the way classification, in particular binary classification systems, such as healthy and sick, male and female, dirty and clean, were embodied in the buildings designed for the treatment, and the way these reinforced inequities through bricks and mortar of our world. Please note that the language and the terminology used to discuss people with health problems in the past was often derogatory, offensive, and stereotypical. And as a historian of the terms and phrases that were applied can be seen as evidence of the attitudes of the time as well. The separation of different social classes has impacted on the lives of individuals and the health of the populations significantly through time, with the singling out and isolating of those who were feared because they were ill or afflicted with disease occurring through the ages. Socioeconomic, racial, and gender-based and age characteristics were other layers of classification also used to differentiate people and the care they received in these amenities, which they had access to, something that can be read from the plans of buildings literally, written in the rooms' names. By exploring this, we may be able to reflect on our own ideas and around labels and room names and see how these made concrete and perpetuated inequities. The ability to physically segregate or separate classes of people and objects has long been one of the defining characteristics of architecture. Walls, doors, and fences crystallize ideas into physical space. Rules and regulations, indicated by signs, locks and keys, and gatekeepers, allowed certain groups access to spaces to the exclusion of others. Differentiated entranceways and separate quarters for men and women, first and second class patients, and services and amenities that were differentiated on the basis of a patient's class, race, and gender and ethnicity, as distinct from any medical rationale, were features of many health-related buildings of the past. However, separation of individuals was medically advised, placing physical distance between sick people and places and those who were healthy, as one of the ways seen to halt disease transmission, something we've all had first-hand experience of during COVID. Quarantine stations were the architectural barrier to epidemic outbreaks and functioned to examine, quarantine, isolate, disinfect, and treat travellers and cargo in order to contain infectious diseases such as plague, cholera, and yellow fever. And here we can see the quarantine station in Sydney, Australia, which had separation between the healthy and sick grounds, surrounded by fencing, with guards employed to patrol the border. But by the 1880s, wealthy passengers were accommodated in a separate enclosure, which was also fenced. And in the early 20th century, additional accommodation blocks and separate kitchens and ablutions facilities were built for those classified by authorities as Asiatics, replacing tent accommodation they had previously used. The classification and separation along lines of healthiness, socioeconomic status, gender, marital status, and race introduced further needs for distinct and separate buildings and compounds, leading to a village-like appearance of small buildings scattered across the site. People suffering from disfiguring diseases, such as Hansen's disease or leprosy, were also often shunned and isolated by society. And segregation was reinforced by legislation and was used as an instrument to forcibly isolate them in the 19th and 20th centuries. Religious orders had a tradition of caring for those with leprosy in institutions separated from the general population, a tradition they continued even after the discovery that the disease was caused by bacteria with a low level of contagiousness. Such separation of people along lines of gender and race was additionally seen to have eugenic implications as well. In 1907, a purpose-designed lazaret was opened on Peel Island in Queensland. The government felt that it was essential to have separate compounds to segregate the coloured from the white, the male from the female, as well as the isolation of facilities for the sick, and consequently, 8-foot-high chain wire fences bounded the different areas. The accommodation of the huts for the white patients were, and I quote, lined with ceilings and ventilated, with a French light and a large window, and furnished with a 4-post bedstead, table, chair, and chest of drawers. By contrast, the huts for what were termed the coloured patients were constructed of rough timber framing, clad with tea tree bark, low ceilings, and earth floor, and accommodated more than one patient. When numbers increased, tents were used for sleeping quarters and extra, quote, coloured patients. And in 1908, with the deterioration of the bark cladding, corrugated iron sheeting was substituted. The difference in design and quality was clearly apparent. The act of isolating people was also applied to those with mental illnesses. Brislington House, England, was built in 1804 and was a private asylum for pain patients. Separation through the construction of 7 buildings, each with their own walled outdoor area or airing court, allowed for classification and separation by gender and socioeconomic background, but also for the short-term segregation based on behaviour. This plan shows these categories in ink on paper, reflecting the intentions of the asylum and leaving a trace of the use for the building for historians to read. In conclusion, what I've aimed to show in this brief talk is how architectural records and artefacts from which social and cultural histories can be read can be used, including the plans, photographs, and publications. We can discover much about the ways people and their illnesses were perceived and treated, and how inequities were able to be reinforced through buildings. This hopefully has shown how archives can inform teaching and practice of architecture, as it is through looking at architecture of the past that we can actually hold a lens up to ourselves and our own ideas, and hopefully move in a different direction. Thank you.
Thank you, Julie. And Kadir, the floor is yours.
Okay, thank you for inviting me before, and nice to meet you all, the participants for the panel. I'm sharing. Okay, I'm gonna tell a short story of an old building, a simple building which we transform into a surgical instrument and health museum in Samsun Black Sea region. Samsun is the Black Sea region of the Turkey, and the building is in the on the seafront and very close to the city center. And this is the building is taken a picture from the 2008. It is a wagon repair workshop building. Is a train wagon repair workshop building, as so needed to be restored in the time. And this is another picture in another view. So this is the Samsun administration offers to make this building serve as a surgical instrument museum, because there are plenty of surgical instrument company which are produce surgical instrument in the and export worldwide in Samsun. So in this way, these are some of them the surgical instrument company that I put in here. And in this way, the aim was to introduce the local people to the sector that provides significant economic contributions to the city, and about health equity and the public health, and bring the people together, which are professional together, and about in this subject. So during this process, the restoration has begun, and we were prepared, and we started to working on the exhibition or on the museum project. So, however, when we started working, the administration has changed. So therefore, we did not have any inventory data or any collecting artifacts and anything about the exhibition. So we started the research for collections and the documents for the exhibition setup, and where we aim to develop a historical perspective on the topics of health, equity, and the public health. So we reached a person that name is Haluk Perk, is the one of the important collector of archaeological collector in Turkey, and he agreed to exhibit his important healthcare collection for this museum and for this purpose. So the main thing is we offer to use the middle of the buildings. In the middle of the building, there is a wagon repair ditch. So we transform that characteristic feature of this building from its previous use into exhibition. So this is the main topic of the exhibition. Is a kind of a timeline, is the history of the surgical instrument and its documents and some artifacts, and we offered a kind of a main exhibition in there, and the side exhibition we distributed around this main exhibition, main spine. We call this as a spine. You can see the old photo of the ditch in there. So it's a different use, but we protect this ditch and the use as a main exhibition line. So the other areas we transform in the different thematic exhibitions is including I mean very wide range artifacts from from the Anatolian civilization to the Roman period, and from Industrial Revolution pieces from the documents to the Ottoman period. It's a very wide range of artifacts we found from the collectors. And this is the distribution of the function as a main exhibition area, is a history and development, medicine, surgical instrument produced in Samsun, eye surgery, dental surgery, gynecology, doctor research room, patient care rooms. So we did not able to put all this kind of artifacts in the area, but because of some issues, but the generally is done. The upper level is about the storage space, technical room, management office, foyer, and auditorium. This is all the exhibition you can find in the ground level. So I want to show you some example of from the collectors artifacts and that we use in the exhibition. And for example, there's a dentist chair in there, and this some collecting from the old time in the Samsun area when they produce to use for production to the surgical instrument. There's a you can anatomy documents from the Ottoman period. This is a very unique example of the artifacts in the exhibition. This is the important thing for to show. I wanted to show you about the health equity in the past, to understanding the health equity in the past. This is there is a watch in there. It's designed for blind individuals to understanding the time. And the second, there is a documents in the middle of the screen. There's you can see there's some alphabets that developed for to understanding the disabilities. And the right in the pictures, there's I think the 16th or 15th century, the Ottoman period is shows is eye surgery, how they do this. This is important to tell the people the history and the documents what we have in the public health in the past, and now to discuss about to compare the time. This is important. This is the main structure that you can use. See the section in here, and we support the exhibition with the digital immersive narratives and some games, etc., and the documents and the artifacts, and you try to understand the history of surgery and for everything. But in here, for the opening, this section is you can see the ditch and how we set all the exhibition up to in the main area, and you can see the site exhibition, thematic exhibition in there. So the main things in here, I will show you some photos from the recent photos of the museum. This is very simple, and you can see the disabled the production from the past in the exhibition, and this is important for, I mean, to support the disabled people. They wanted to open with this kind of artifacts. They choose this kind of artifacts to show, and you can see the main axis in here, and this is what we did in the exhibition. So we couldn't do all the things. Like we believe that the several exhibitions should be developed in here and updated in the context of the public health and for everything. But the museum management, we believe, need to put some topics for like the climate crisis in here, because it's very connected with the public health and the impact of agriculture, the effect energy production, water resource consumption, migration, food security, and the rights of future generation, which is very related to the health equity and the public health. I think this is there's some photos from the exhibition. That's all. I hope I put the exact timing.
Thank you, Kadir, for your answer. And now we have a question and answer and discussion session. We have question and answer and discussion session. And in our chat box, we will be very happy to get the questions by our audience. And before that, I would like to ask one more questions to each panelist with respect to their expertise fields and studies. For our limited time, I would be happy if your answers take 2 or 3 minutes maximum. And I would like to begin with Julie. And Julie, as an architectural historian, curator, and active researcher, you have several publications, and including climate, which is among top urgent and global issues and very related to health equity. And what would be your suggestions for collaborations between teaching and archival communities in architecture to develop historical documentation on climate justice with an emphasis on health equity, such as historical documentation on climate responsive architecture design for underserved, underrepresented communities, etc.? I would be happy to know your answer.
Thanks, Meryl. Yeah, I think we can learn a lot from looking at the history of climate, health, and architecture, all 3 of them simultaneously as well. In the past, climate and health were linked very closely in people's minds, as was architecture and climate in terms of the response of architecture to different climates. And while access to what were seen as healthy climates really left populations in general at the mercy of their geographic regions, it can be seen that throughout history, the ability to moderate these effects of climate have always been influenced by social and cultural factors. Indeed, it's really only through exploring history and archives that we've been able to recognise these kinds of changes. And in the case of climate change, which is impacting us now, it's by comparison of climate data held in archives, as well as, ice cores, that we've actually been able to understand that this indeed is a real thing that is happening. So I think the importance is archives is that we can actually monitor change through archives. Without that, we can be sometimes basing it on other things. So I think that's one thing. And the access to healthy climates for human life can also be seen to be dependent on these social factors I mentioned, with the wealthier people, for example, often moving to areas with a more moderate climate. For example, during summer, wealthier people tended to go to their homes along the coast or up in the hills where it was a bit cooler and there'd be sea breezes and things like that. So the health facilities for these richer climates were often situated in gardens, in natural environments, in well-designed buildings and landscapes. So it's important for us then to use that lens once again to reflect back on our own practices and our own teaching. So if we can recognise these differences which occurred in the past and interrogate our own designs, looking at these things, we might be able to enable a more equitable way of designing going forward. So I think it's that recognition and interrogation of our own practices that history and archives can actually lead us to do.
Thank you. And now I would like to continue with Kadir. In relation to his experience on health museum and teaching, what would be his suggestions to connect health museums in architecture education and interior design education today, with a focus on health equity? Because in particular, Kadir has an experience as an instructor in interior design as well. So interior design and architecture disciplines, their connections are very vital for our post-pandemic healthy life. What would be his suggestions?
Yeah, I can explain, some of this under few topics maybe. The interdisciplinary team, the building is very important, I think, because we are working on interdisciplinary, and the students must be learn more working with the interdisciplinary ways. This is important. And one is the sharing the data and research, which is very important. Maybe is the there could be an open source data collections, and everybody can reach on them. And because generally we can reach everything about the architectural text, or some lots of data in everywhere in social media, but in the context of the health equity or the public health, and for everything, it is I think it's a bit lack of not so much data to collecting this kind of things. And maybe it can be designed in between spaces. I don't know how, but we are thinking on this kind of works. The people can come together in the space. It is not like a school, or not a individual offices or something. This is a kind of a common public places, and the people can come together in there, and from different professions, from the health professions, from the scientists, some people who work on the climate crisis, and some activists or something, and with the architecture students, or teaching assistants and professors from the architecture, and come together and to make can produce more different ideas about this subject, I think. Yes.
Thank you, Kadir. I think in architecture, for health equity, we need much more holistic and multidisciplinary and interdisciplinary understanding for a healthier built environment, I think, right?
Yes, I agree with this. And we had different work on the Istanbul in maybe you heard in Müze Gazani. It is the main topic is the climate crisis in there. Inside is the climate museum, but the other the functions are the supporting the climate museum, because it is the climate crisis is related for everybody, because it is a global thing. So the people shares everything what they produce, get together, and produce an idea in there, that we try to create some spaces like this.
Thank you, Kadir. And now I have a question for Nilay. And Nilay, in one of your recent published interviews, Architecture as a Tool for Inclusion in this year, you have been saying that even architecture professors said that disabled people were not a significant target for architects when you started teaching universal design. First, I think that this sentence is very important clue for us why we should push education system for inclusive design, for health equity, and for other issues with perspectives on equity. And my question is, what would be your suggestions for a more inclusive and responsive curriculum in architecture, including health equity in Turkey today, in particular by considering the COVID-19 pandemic experience, climate emergency, and in particular by considering, for instance, recent earthquake in a country? What would you like to say about that with a focus on health equity, teaching, and or today current challenges?
Thank you, Meral, for this question. As I told you in my lecture, in my speech, I believe that universal design is for healing the world. That's why I give this lecture to interior design and architecture design students in the faculty. And as you told me previously, and I believe also we should create a holistic view in design, and we should try to understand what is normal. I mean, we should think about the user-friendly design, but diverse users' needs, wants, and details we should understand and give the information to our students. In another terms, maybe I can say if we do not see the problem, we cannot fix it. As a result, we should create an empathy, as underlined in my lecture as well. We should not neglect this reality. If we couldn't create empathy, we cannot do anything. Some people will stay always segregated. Like this panel, we should make more get together. This is a good opportunity, I think, but we need our students as well. Right now, we are talking as a professional and as educator or as practitioner architect right now. If this kind of seminar motivation, aims and motivation increase, this will be helpful for students as well, I think. I think this is all right now.
Okay, thank you. And Arun, I have a question for you. And you have a strong industrial link teaching with a focus on design for health and well-being in architecture. I would like to ask, what was your motivations for industrial link teaching with a focus on health and well-being? Have you noticed some gaps, and what are its benefits for teaching in architecture to gain knowledge on health equity with respect to or current challenges such as pandemic, climate crisis, and some problems with food systems, renewable energies, etc. And what would you like to say that briefly?
Thank you for the question, Maral. And as you said, I do a lot of industry-linked teaching involving industry partners and real-world projects in the architecture studio wherever possible. It brings with it many challenges, but I think one of the major benefits of bringing industry in is that it functions as that link between teaching industry and research practices. And the exposure our industry partners have to new ideas and opportunities for thinking differently about some of these healthcare projects or in any of the fields where we're working. So we also work in some of those other areas around natural disasters, food systems, those types of things. But by bringing the industry in, we almost give industry license to do things differently because they're engaging with students, they're engaging with academics. And one of the things I'm really keen to pursue further is how we can use some of these industry links to encourage greater documentation of projects. And so we can start to build the archives of the future around some of our attempts to engage with underserved communities or to bring new voices in. I think, as Julie mentioned earlier, archival documentation is really our shared memory. I think the connection between our large student cohorts and our teaching practices and some real-world projects provides a really unique opportunity to have just a sheer workforce to document a lot of what's going on and a lot of the discussions that are being had when we are actually going out and engaging widely with a lot of communities. And I think that's really how we can, as Nilay mentioned, connect with the empathy that we're building, connect with the lived experience, and actually provide a record of that. I'm not sure if anyone else has tried to find documentation of past projects and how they've engaged with communities, but it's very, very hard to find anything other than the building as evidence. Those processes are almost entirely lost. And so I'd set a challenge to this panel or to people watching to actually see an archive as archiving processes as well as archiving the physical footprint that's left behind, whether that's health equity or some of our other areas around climate emergency, natural disasters, or food security. All of those things, I think we need to get better at documenting and archiving our processes as well as the artifacts that we kind of produce at the end.
Thank you, Aaron. And finally, I have a question for Elke. Dear Elke, in addition to your teaching and research collaboration efforts on equitable spaces within health, as far as I know, in June 2020, you also defended your PhD dissertation in architecture on health promotive building design. So in light of your PhD experience, in particular in June 2020, in other words, during the pandemic, it's very important for us, a PhD on health and architecture. Very briefly, what would you like to say about the role of PhD dissertations in architecture today and PhD programs to understand health equity deeper and to enrich our perspectives, teaching and to enrich our perspectives, perhaps the historical documentation, collection criteria, etc. Very briefly, please.
Yeah, so much to say, but I think what I loved about being able to do my PhD in Chalmers University that is quite close to practice. It was a topic, sort of the bigger topic was posed by the municipality and the local governments responsible for healthcare and health equity. So being able to work on issues that were actually present and deep dive into things as a PhD was amazing. I was lucky that I had both a supervisor that was an architect, construction engineer, as well as a nurse, professor in nursing sciences, which you also saw on the Aaron Davis slides, Marie Elf. And that also made it beautiful that I got to talk to her PhDs that were on the nursing school. So I was on the architecture school. So within our little bubble, we became that interdisciplinary group, talking about these issues and their perspectives on what space and place is, and versus what how I experience it as an architect and my role in that. We also had quite discussions about who is supposed to be researching what. Should I even be doing interviews with healthcare professionals if I am not one myself? Do I understand them well enough? But I think there was also a value, and we could see that the kind of questions that I would ask would be different, and the kind of things that I would hear would be different. And I was lucky that throughout my PhD, I was teaching constantly in these topics. So with the students, I could lecture my first outcomes, but also hear what did they actually hear, or what kind of design implications did they develop. And so this constant interaction was amazing. And you could see that right now the topic due to COVID, whereas in the start I needed to explain this to people why it's important, and I don't need to explain it so much anymore to the general audience. And there's much more interest from students also to study in this direction, and not just a master, but like really get into the depth of the topic. Yeah, is that
okay? Thank you. So is there any question from our audience? Okay, I would like to ask a question from Kadir, the question by Nasim. When visitors enter the museum, will they find any information about the history and previous use of building? Does the museum provide any exhibits or displays that share the story of the building's transformation into a health-focused museum? Kadir, what would you like to say that?
Enter the museum, will they find? Yes, they do. The visitor can find a small information about the building and what is used for before, and then just the health-focused museum. The exhibition is about the health-focused museum, and but you can find information about the building and what it's used for before. Just I can say this.
Thank you.
But it's not a main information or main exhibition thing in the museum.
Thank you. Any question?
I have a question that I would like to ask.
This is the question for me.
Because if you're including the community in evaluating spaces, designing projects, sharing their experiences about using health-centered architecture, quite often people will be more aware of the aspects of the design that are causing challenges or impediments to them or excluding them. And they will be more able to discuss that than they will be able to make observations about the aspects of the design that are more successful. For example, the lighting or the access to fresh air, they might not notice it as much if you sit them down and ask them to reflect on spaces. So how can you, as practitioners and archivists, take that knowledge about perspective and use that in your research and your practice?
I can say we are not expert for everything, so we are working with the interdisciplinary way in this kind of works as especially in the museum. We have some expert professionals about for example in here there was no professional in the beginning about the health or something. So we need to explore, research about to understanding what we will do about. For this museum, there's a health administration in the city, and from there are some professionals that give some advices and some briefings and some information about what we are doing about the exhibition. In the other way, it depends on the project, but in here we found a collector, and we met with the collector, and he has 3 books about the health collections, and very interesting. There are lots of collections from the antique collections from the Anatolian civilizations and everything. So he helps us to making documentation for the museum and for everything. This is the other side. This is the exhibition thing. But in the same time, we had some experiments that work with the lightning design, and we work with the art, digital art artists installation that do something, lots of works from all over the world, and we work with some projects, in individual projects, and we come together and we produce something as for the project, but what we work on. So I can say this.
Okay, thank you. And I think we are getting close to the end of our time together. And I think that all panelists today present their presentation have shown us that health equity is a multidimensional concept and demands holistic perspectives. And firstly, we need to create, I think, much more inclusive opportunities to actively listen to disadvantaged and vulnerable communities, and to connect them, to learn their current struggles and expectations for health equity within the post-pandemic built environment. And I think that today, more than discussion, it's time to take collaborative actions with effective methods. And secondly, I think that in architecture teaching, we should listen to the teaching community to learn how they identify gaps within this context. What are their current effective strategies to integrate health needs of disadvantaged communities into their courses, into their pedagogy, and what are their invisible or visible obstacles within education? And in architectural teaching, I think we should listen to the teaching community to learn how they identify gaps within this context, and what are their current effective strategies to integrate health needs of disadvantaged communities into their courses and pedagogy. And thirdly, we need to revisit our collective memory on health equity in architecture to support teaching, research, and learning communities in the field. In other words, architecture archives and collections. And finally, at that point, I would like to share a few critical issues in relation to my own experience. And according to my archive-based research studies in architectural, her story from the United States perspective, at leading schools of architecture, firstly, there is a huge gaps in their architectural archives and collections on underrepresented minority and immigrant communities and individuals from their own past, past, in spite of all critical discussions on inclusion and equity in American architecture today. And secondly, it is impossible to reach data on their diverse contents in architectural archives at schools of architecture in the United States. In other words, we do not know how diverse their contents. And thirdly, it is impossible to reach data on diversity in their archival and curatorial teams. In other words, we do not know who have been creating and developing these architectural archives at leading schools of architecture. So we need data, and from current pictures, it's possible to say that architectural archives do not seem to be responsive to our urgent needs for teaching, researching, etc. And finally, during our panel organization process, it has been a challenge for me to reach out to an archivist or a curator in architecture working on health subjects in spite of this discussions on these topics. I hope today our panel can stimulate collective actions and collaborations among diverse teaching, archival, and curatorial communities for health equity in architecture. And today, as the panel chair, it has been a pleasure for me to be all of you today. And I am thankful to everyone. And I wish we could meet again at another event to discuss healthier architecture for all. My best wishes to everyone. And Angela, please, the floor is yours.
Thank you so much, Meral, and to Elke, Aaron, Nilay, Julian, and Kadir for sharing your interesting projects and your insights on these questions. It's been a wonderful discussion, and we appreciate having you here so much. And I agree very much that I hope we can continue this discussion and that this inspires people to transform some of these thoughts into active practice. So thank you all very much. Great.